Hi, I am so elated to meet you in the program of 3 p.m. 3-point medics. We have been discussing hyponatremia in many sessions. We have come to a stage where we have seen what is hyponatremia, the causes of hyponatremia, in fact how you can evaluate hyponatremia. So just I want you to recall once again, when you find hyponatremia, the first investigation you are supposed to do serum osmolality. We expect serum osmolality is less than 275 milliosmolality. Normal serum osmolality is 275 to 290 milliosmolality per kg. When you have hyponatremia and serum osmolality is less than 275, that means you have confirmed that you are dealing with true hyponatremia. There are few causes of pseudo hyponatremia as well. We have discussed so many times in last session. Once you are convinced that you are dealing with true hyponatremia with serum osmolality less than 275 milliosmolality per kg, then you order urine osmolality. Urine osmolality we consider always as a game changer. By doing urine osmolality, you can segregate 16 causes of hyponatremia into 4 causes as one group, 12 causes as another group. So when urine osmolality is less than 100, that will fit into one group. If it is more than 100, that fits into another group. If it is less than 100, 4 causes you should not forget. One is psychogenic polydipsia, and second one thanniparty, that is Bayer potamania. Third one T-party, T-toes syndrome. Then fourth one vachchu seiyrathu, that means administration of 5% dextrose or 0.45% normosaline knowingly or unknowingly. So these are the 4 causes that should be picked up when you have urine osmolality less than 100. If urine osmolality more than 100, then headache starts, because the rest of the 12 causes to be explored. When urine osmolality more than 100, that means 12 causes are there. So among these 12 causes, you can segregate into 2 groups by doing urine spot sodium. If urine spot sodium is less than 40, that fits into one group. If it is more than 40, that suits into another group. If it is less than 40, if urine spot sodium is less than 40, that indicates kidney is absorbing all the amount of sodium from the urine. So your urine spot sodium is less than 40. So that means hyponatremia due to non-renal cause. That's why kidney is able to absorb sodium. What are these non-renal cause? Non-renal cause is nothing but hypovolemia. The causes of hypovolemia into 2 categories. Causes of true hypovolemia like diarrhea, vomiting, sweating, burns and intestinal obstruction, peritonitis and so on. These causes will propel the kidney to absorb more sodium, resulting in urine sodium less than 40. If it is urine spot sodium more than 40, then your kidney itself leaking sodium in the urine, which is responsible for hyponatremia. So far we have seen almost all the causes. This session is going to address the causes that is responsible for leaking sodium in the urine. I mean urine spot sodium more than 40. You can remember 4 important causes. The 4 important causes, out of 4 causes, 2 endocrine causes, one hypothyroidism and second one mineralocorticoid deficiency. These 2 endocrine causes produces urine spot sodium more than 40. Then another important 3 causes, I could say, one SIADH, and second one thiazide diuretic, and third one cerebral salt wasting syndrome. So out of these 5 causes that is responsible for urine spot sodium more than 40, we commonly witness thiazide diuretic and SIADH, even though we rarely encounter Addison disease and cerebral salt wasting syndrome and even hypothyroidism and so on. So, we used to witness SIADH very common. When I was doing my postgraduate in Madras Medical College, at that time my nephrology professor Edwin sir, he used to always write down SIADH as the diagnosis within seconds. That always prompted me to know about SIADH in detail. Now SIADH is one of the very favored and interested topic to me. So we commonly diagnose SIADH in many occasions as a cause of hyponatremia. Now we have come to a conclusion where how SIADH can be diagnosed. So one by one I want to say, when you want to say SIADH, first investigation serum osmolality, that serum osmolality should come as less than 275. Once serum osmolality is less than 275, then you have to do urine osmolality. By doing urine osmolality, then less than 100, 4 causes, then more than 100, then 12 causes. Among these 12 causes only this SIADH comes. So naturally your urine osmolality will be more than 100. Then out of this, once urine osmolality is more than 100, out of 12 causes you will do urine spot sodium. Then urine spot sodium, when it is more than 40, then SIADH comes. Or otherwise I could say, if you want to prove SIADH, serum osmolality should be less than 275. Then if you do urine osmolality, that should be more than 100. And if you do urine spot sodium, that should be more than 40. So when these three parameters have proven that you are dealing with one of the cause as SIADH, then you have differential diagnosis. As I told you earlier, SIADH, hypothyroidism, mineralocorticoid deficiency and so many things. Then how will you prove, or it is certain that you are dealing with SIADH? To prove SIADH, other than this decreased serum osmolality, urine osmolality more than 100, urine spot sodium more than 40, then you have to prove that you don't have any other endocrine abnormality. So you should have normal thyroid function test. You have to prove that normal cortisol level, that means there is no deficiency of mineralocorticoid or there is no evidence of Addison disease. Then you have decreased serum uric acid. Sometimes it is as low as 1.7 in case of SIADH. Then you have to prove that neither patient has hypovolemia nor hypervolemia as clinically. So these evidence are pointing out that we are dealing with SIADH. So today what we have seen, if urine spot sodium more than 40, the most important common causes are SIADH, hypothyroidism and mineralocorticoid deficiency, thiazide diuretic and cerebral salt wasting syndrome. But what we commonly see, thiazide diuretics, because we use very commonly as an antihypertensive drug. SIADH, there are so many causes behind SIADH, then we rarely come across endocrine abnormalities as well. In cerebral salt wasting syndrome, those who have subarachnoid hemorrhage or any kind of brain pathology, and you will have increased natriuretic peptide that is responsible for diuresis. So the main difference between cerebral salt wasting syndrome and SIADH is volume status. In cerebral salt wasting syndrome, you will have hypovolemia. So you have to replenish the patient with IV fluid. In SIADH, there will be slight volume excess or normovolemia. So you require fluid restriction. So there will be a great distinction between SIADH and cerebral salt wasting syndrome in the form of fluid administration. One entity requires fluid restriction and another entity require liberal fluid intake. So anyway, this hyponatremia is one of the toughest topic, but still we are trying to explore in a very simple way. But I have fervent hope that when we repeatedly discuss hyponatremia, definitely that will make lot of inroads into your mind. Thank you.